Well, thank you. Rachel apologizes for not being here, but you cannot always predict the arrival of twins with certainty. So she is home and safe with two healthy babies. So I'm hitting for her today, which is low-grade serous cancer is Rachel's area of study. She leads our low-grade serous ovarian cancer team here. So I will try to do her work justice. As you all know, from many talks today, that serous cancers of the ovary really are two distinct diseases. We've been talking a lot about STIC and high-grade serous carcinoma, but I'm going to sort of focus on the other serous cancers, the serous borderline tumors and low-grade serous carcinomas. I know that, that we see in the clinic and are a bit challenging to treat. This is a very interesting publication out of MD Anderson. It was published in 2006, and it was an excellent review because they went very far back in time, which proves to be very important when trying to understand how these tumors are going to behave and how to counsel patients over the years. It is very clear that long-term follow-up is needed to really measure the rate of recurrence of patients with serous borderline tumors with non-invasive implants on the order of 10 to 20 years, which is something that we're not used to when thinking about solid tumors. So if you look at serous borderline tumors ending up in the clinic, a large proportion are stage 1. Those with advanced stage disease essentially having disease outside the ovary, stage 2 to 4 disease. There's a small proportion that present de novo with low-grade serous carcinoma. I have several of them in my clinic, young women with even stage 4 peritoneal involvement at diagnosis. But a lot of patients present with non-invasive implants. And we sort of call it the 40%, 80% rule here, so that if these non-invasive implant patients, about 40% recur, and of those, 80% really have invasive disease or low-grade serous carcinoma at that point. So in the clinic, we are treating these patients with low-grade serous carcinoma either as their primary diagnosis or a recurrence after a serous borderline tumor. And the importance of this disease is that you start this table up here with some diseases that really have relatively low morbidity and mortality to a disease here where patients universally almost succumb to this disease, that this is a disease that it may take a longer time course, but the patients do die from it. So what are the features of low-grade serous carcinoma? It tends to occur about a decade younger than high-grade serous carcinoma. It presents a very small proportion of our serous cases, only about 10%, where 90% are high-grade serous. Very different molecular genetics. This is reversed, I'm sorry. I made too many slides this week. All right, so the high-grade serous carcinomas we've been talking about a lot today, are P53 mutant, BRCA mutant, and otherwise HRD defective, and low-grade serous. It's really the MAP kinase pathway that's involved. An interesting study was done on a GOG study. GOG 158, for those who are not in the clinical trial world, was an initial therapy trial for ovarian cancer where it compared paclitaxel and carboplatin to paclitaxel and cisplatin. It included all patients with stage 3 cancer who were optimally debulked, so an advanced stage group. So this retrospective study was done in the arm that ended up being the standard of care arm, the paclitaxel carboplatin arm. They went back and pulled all the pathology slides from this study. So in the GOG trials, there's been a long history of central pathology review and storage, originally of slides, now digital images, so that these were available for this retrospective look. So they did a blinded pathology review with a group of pathologists to place these patients into low-grade and high-grade serous cancer categories. At the time the study was done, there was a 3-tier system in process, so they went through the process. And what you can see here is that these advanced stage low-grade serous patients have a longer progression-free survival as well as overall survival. So it just shows the challenge of measuring outcomes of treatments in these patients where the follow-up time to meet your endpoints is very long. Another interesting retrospective study out of MD Anderson looked at those rare patients that do present with very advanced disease that were appropriate for neoadjuvant chemotherapy. So you really had measurable disease on radiographic imaging to evaluate, and the response to chemo was very low compared to the almost universal responses you see in high-grade serous cancers. This is, again, Dr. Gershenson has spent a great amount of time sort of defining the characteristics of this disease. And low-grade serous carcinoma is chemotherapy resistant. They did this retrospective study, 58 patients, 108 treatment courses, all with recurrent disease, and came up with a response rate of only 3.7%. One patient with platinum-sensitive disease had a CR, and then 3 PRs, 2 in the platinum-sensitive and 1 in the platinum-resistant group. So very little response to the cytotoxic chemotherapy that we are so accustomed to using for high-grade serous patients. Again, with hormonal therapy, 64 patients, 89 treatment courses, recurrent disease patients. Here, a response rate of 9%. 5 CRs in platinum-sensitive patients, 1 CR in a platinum-resistant patient, and 2 PRs in a platinum-sensitive patient. So overall, some activity, but not very high level. But hormonal therapy remains something that we do employ in the clinic. 2 retrospective series, relatively small, looking at the effect of bevacizumab in low-grade serous, one from MD Anderson, one Rachel's series here, both 17 patients. The numbers lining up on this slide are kind of funny for such a small trial, but here at MD Anderson, 13 were evaluable for response by RECIST criteria, all got the bevacizumab in combination with chemotherapy, which is rather standard in recurrent ovarian cancer, heavily pretreated, and showed a response rate of 39%. In our series, similar, 15 evaluable for response, most getting in combination with chemo. It's very similar response. These are small numbers, retrospective series, but some indication that this might be an important target or an important modality for these patients that sort of improves the results of cytotoxic therapy. We talked earlier during Doug's talk about the average number of somatic mutations per tumor in ovary cancer running around 60, whereas something like melanoma being over 400. The low-grade serous carcinomas are very genomically quiescent, less than or equal to 10 mutations per tumor. In 2 publications here in our series, I'll show you later, we came up with a number of 2. So these tumors are very low in mutational burden. So this is Rachel's retrospective series that she did. She found 75 patients and ran all over the hospital, find out where they had appointments, where they were coming, and got their blood and got their consent for this IRB-approved study to do this analysis, and did a clinical as well as genomic characterization of these patients. We had 56 serous borderline tumors, 19 low-grade serous patients in this cohort. This was done on a sequenome platform, and you could see that 22% of the patients with RAS mutations, 35% with BRAF mutations, and 43% wild type for both. But what we've all come to understand when thinking about targeting these treatments is that the BRAF mutations are associated with early stage disease and serous borderline tumor histology. So it's a finding that's not present in our patients who need therapy. So thinking of using a target such as vemurafenib for a V600E mutation is not going to be very relevant to the patients in our practice. And not hold true for KRAS mutations, which are present in both low-stage and high-stage patients, as well as in low-grade serous and serous borderline tumors. The biggest association, again, with the BRAF V600 being indicative of low-stage and serous borderline histology. We only had 1 patient with low-grade serous carcinoma with a BRAF mutation in our series. So if we cannot target BRAF, how are we going to get at this disease where we know that the MAP kinase pathway is aberrant? And the choice, appropriately so, was to target MEK. So the first study was done by the Gynecologic Oncology Group, study 239, where selumetinib and MEK inhibitor was given as therapy to women with low-grade serous carcinoma who had recurrent disease, measurable disease, and had no restrictions on prior therapy. These patients did have a central pathology review by the Gynecologic Oncology Group as part of their treatment. The selumetinib used here, I mean, this trial was started back in the day, if any of you remember, where we had pour and mix selumetinib. It came in bottles and it smelled bad, and you had to pour it together and mix it, and the patient had to drag around a cooler, and then the tablets became available during the course of this study. And we all sort of know that that formulation of selumetinib wasn't very potent, and there's data in melanoma that as you move to better MEK inhibitors over time, that response rates went up, and even in those patients. So there was a 15% response rate here, 8 out of 52. Perhaps a better formulation would have gotten a better result, perhaps not, I don't know, but further studies in progress. And when you look at this patients here who, there were 52 on the study, 34 there was tissue available for analysis. Of the 8 responders on the study, there was tissue available on 7 of them. And what you can see here is that on this sequenome type analysis that was done, there was no correlation between BRAF or KRAS mutation status and response. Of the 7 responders, they were all BRAF mutation wild type, BRAF mutation negative, and of the 7 responders, 5 did not have a KRAS mutation and 2 did. So this was not a predictive biomarker for response. As I showed you on this trial, there was one complete responder. This complete responder was a Memorial Sloan Kettering patient. We went on to study this tumor in our extreme outlier analysis program run by Dave Sollett here at Memorial Sloan Kettering. And Rachel just published the results of this. I'm going to run through that. So this is our patient on the selumetinib study who's a complete responder, really an extreme responder. She remains in a complete remission over 5 years from entering this trial in 2009. This was a patient who had intraperitoneal therapy at diagnosis for advanced disease. This patient went on to get 3 subsequent lines of chemotherapy for recurrent disease and failed all 3, had extensive peritoneal disease, and received hormonal therapy with tamoxifen prior to entering this trial. This is an example of one of her sites of disease. She went into remission at this point in the trial, a complete remission, and remains so to this day. She's in her 50s and a mother of 3. So this is the figure from the publication, again, showing the response occurring in 2011 and sustaining in year 4 and 5. And when this tumor was subjected to next generation sequencing on our impact assay that you heard about today, what was seen, here's the tumor, here's the normal, was this deletion that really consists of these 15 nucleotides that span this 6 codons here and results in a deletion of 5 amino acids. When you look over here, this is the amino acid deletion. It's really adjacent to this negative regulatory helix. This is a novel finding. It had not been previously reported, but we did detail here how this similar findings have been reported in other disease types in the adjacent areas. Probably the 2 most common are depicted here, the K57H. These both have been really detailed as really oncogenic drivers. So this is a novel finding, but again, neighboring abnormalities very well documented to be tumor drivers. The deletion, this is the wild type ribbon structure. Our deleted area would be depicted in the gray here. And when you do structural modeling of the effect of this deletion, you can see that the binding site for this selumetinib is retained. And what changes is that it disrupts the interaction between the negative regulatory helix and the core kinase domain, so causes constitutive kinase activity. We further went on to explore this, and when you transfect in this abnormality, compare it to the well-known oncogenic driver with two controls, the blank vector and the wild-type MEK, you can see this constitutive activity of the pathway by phospho-ERK and phospho-S6 activation, and you can show that the responsiveness, the allosteric binding site to the selumetinib is retained. It retains the responsiveness of the wild-type MEK. On a soft agar assay, you can see that this is oncogenic in terms of colony formation, even more so than the defined abnormalities that we made. We did take those 75 original patients, and on the 42 we had enough tumor, fully sequenced them, and we did not find another patient with this abnormality. We did have material to take 29 of the additional patients and subject them to impact assay, 18 low-grade serous and 11 serous borderline patients that are detailed here, the serous borderline in the light yellow and the low-grade serous in the red. And you do see, though, extensive abnormalities in the pathway consistent with previous reports, KRAS, 1-NRAS, BRAF, mutations. We saw 2 BRAF fusions, and this is our patient here that I gave the details. One of the interesting things about this is that we do have another complete responder, a low-grade serous patient to MEK therapy. She happened to be on a phase 1 trial that was giving a MEK inhibitor with weekly paclitaxel. But again, this is an advanced low-grade serous patient who had failed multiple lines of chemotherapy, who represents one of these BRAF fusion, and she also is in complete response now over 2 years. The first patient continued on the MEK therapy throughout her complete response. This patient happened to get pneumonitis and stopped after a course of therapy because the protocol directed her to, and she still retains the CR. So we do have questions for these patients of how long you'll have to continue. This is just a comparison with the TCGA high-grade serous patients and our series of serous borderline and low-grade patients, showing the very clear different genomics of P53 versus MAP kinase abnormality. So 2 big randomized trials are ongoing to follow up on this information. One is the GOG 281 study that is going to accrue 250 patients and randomize them to trametinib, a MEK inhibitor, versus physician's choice treatment, either hormonal or chemotherapy. It does allow crossover at progression. This will be a great source of information about clinical activity, but also a more extended tissue collection so that we can further maybe isolate a predictor of who is most likely to respond to these patients. The second is the MILO study, very similar study there, in this case randomizing to MEK162. But really almost identical phase 3s that are going on. This does come at a cost. MEK inhibitors are not without toxicity. We see the rash, diarrhea, nausea, vomiting, some very troublesome peripheral edema in both the hands and the feet, fatigue, and almost everyone who swallows even one MEK inhibitor tablet will have an elevated CPK in their blood. We largely ignore it. It's been shown to be benign. They're not having a heart attack or muscle necrosis. We do have patients, though, a few who've had to stop treatment due to muscle weakness or pain. It seems to occur after vigorous exercise. Otherwise, the CPK elevations that happen do go back to normal when you stop the drug. Other rare but serious things that happen that cause us to stop this therapy is retinal events. You need a good ophthalmologist at your side to use these drugs. They get central serous retinopathy most commonly. we've seen transient decrease in left ventricular ejection fraction that have recovered, and we see pneumonitis. I've had one patient on the Milo study who developed central serous retinopathy, pneumonitis, and a decreased LVF and elevated CPK. And luckily, she's getting her vision down back to normal with Avastin injections. People do lose sight. It's not, these drugs are not benign. So how about dual blockade? We have a 15% response rate. How can we improve that? There's redundant pathways. There's been one example of that in the literature looking at a combination of MEK and PI3 kinase inhibitor, in this case BKM120 with trametinib, and they in this publication and the previous ASCO report in their ovarian cancer patients either during the escalation phase or during an expansion cohort, 21 total, having a 29% response rate to this combination, 1 CR and 5 PRs. These were not GYN doctors, they were phase 1 doctors, so they didn't do a good job of saying what kind of ovarian cancer these patients had. But again, the MEK inhibitors can be challenging to give. This combination was too challenging to give. There was dose interruptions or reductions for toxicity, and probably it's been very difficult to combine inhibitors in these pathways in multiple trials. I'll give you an example of what drives me crazy in these publications is these sort of tables that say a bunch of histologies here and some grades up here, and you have no idea who was treated on these trials. Obviously, I don't even know what any of this actually means. But you can kind of guess, because 20 of them had either a KRAS or BRAF mutation, so I think that the GYN doctors at these hospitals sent patients with low-grade serous cancer to be treated on this phase 1 trial, and the phase 1 doctors just didn't know it was called that. You can guess by this genotype that's what they were, right? And that's why we see these responses. So please, when you're writing papers and reviewing them, please make people list this out correctly and don't separate histology and grade. It drives me nuts. Okay, so in conclusion, low-grade serous cancers is clinically, histologically, molecular distinct from high-grade serous ovarian cancer. Response rates to chemotherapy are poor. We all still do it for lack of anything else to do. More information is needed regarding the activity of bevacizumab in low-grade serous ovarian cancer. We see some clinical activity in our day-to-day lives, as well as these 2 retrospective studies. We need more genomic analysis of low-grade serous ovarian cancer to identify predictors of response to these targeted therapies, MEK inhibitors. I don't think we need to give it to all, but I showed you 2 extreme responders who had a very clear explanation for why they responded. It doesn't, and I think a lot of those patients, unfortunately, who have other abnormalities just might not get the full benefit they did, but you would hate for these 2 appeared to be cured patients of ours are very happy with their outcome. And MEK inhibitors and combinations of MEK and PI3 kinase inhibitor, although they offer promise, toxicity can be prohibitive, mostly with continuous long-term use. Thank you. Oh, I wanted to show one more slide to acknowledge that all this work was really done by Rachel. She's not only prolific in her research, but in her obtaining of grants to fund this program, and David Solit and Gopa Iyer, who are our scientific collaborators to translate this. Thank you.